Good morning, everybody. Welcome back to part 3 of our webinar series with Anita Meno. We're happy that you could join us for the last session. We are going to start off with finishing up part 2. We didn't get quite to the last breakout room, and so we're going to start with that, and then we'll move on to the part 3 slides. So I'm just going to hand it right over to Anita.
Thank you very much, Sue, and thank you all for joining me today. So we'll pick up where we left off. And as I had mentioned, of course, assessment is a huge component, and we'll talk later on about treatment, but assessment's a big component and being sort of very judicious as to which tools to use. Of course, there's lots of material to present, so I'd like to just kind of continue where I left off in regards to the assessments. And so I'll present to you the Catherine Bergego scale, and then we've already heard about the BIT, the Behavioral Inattention Test, and so we'll have a chance to have a bit of a hands-on activity with the BIT, and then we'll move on to treatment. So here's the Catherine Bergego scale. This is a quick scale that could be done. It's more of a functional assessment that really looks at neglect from the 3 hemispaces. So it looks at neglect of the personal space, which is one side of the body, near extrapersonal space, which is the space within reaching distance. And then finally, it looks at neglect of the far extrapersonal space, which is the space beyond your reaching distance. So what's nice about this scale is that the Catherine Bergego scale can actually assess all 3 spaces. And it's really somewhat of a functional assessment, as you can see, where the clinician simply grades the client based on their performance on 10 different activities. You could also assess for a client's self-perception of USN, if in fact they're somewhat aware of whether they have the USN or not. So you can get them to actually ask, you could actually ask them these questions to see if they're able to recognize that they have a neglect themselves, to sort of test for azoognosia. But generally it's used as a checklist for clinicians to really assess for this impairment. And depending on how the client performs, it could take up to 30 minutes to administer. So it looks at again, direct observation of a client in very functional activity. So it's something that, and the reason why I wanted to introduce this tool is that it could be incorporated in just your general ADL assessment that you do, and wanting to screen for neglect through that observation. So you can kind of, scan through different activities and see if there's a presence of neglect in the various spaces. And so here's the scoring procedure that I just wanted to include in the slides about the Catherine Bergego scale. So fairly quick to score in terms of just rating their level of difficulty for each of the items, and just in order to identify or assess the presence of neglect and the extent of the neglect. In terms of reliability and validity, a very preliminary work has been done to test this tool in terms of psychometric properties, of course, again, which is why it hasn't been recommended in the Canadian best practice guidelines, but I still think it's a very useful tool to use and could be just to, kind of guide the functional observations for USN. So it's a nice tool for that. So here's just some of the preliminary data that was found in the literature regarding the testing of validity and reliability for Catherine Bergego scale. But so far, it's quite promising. And in terms of client suitability, of course, the client does need to be a bit more functional in terms of being able to perform those functional activities. So that's something to consider. So yeah, basically, as well, like if they have other impairments such as neglect, such as apraxia or any cognitive issues, it may be a bit challenging for them to perform this tool. But given that it's a very basic ADL type of assessment, there's very little equipment that's needed, and it could be quite easily administered. So that's the Catherine Bergego scale, and we'll just move forward with the BIT. So here's the task at hand. So what I'd like you to do is to go back into, hopefully you have access to the files for the bit and to administer the bit. So basically, I would like to allocate about 15 minutes for this activity. And so we'll break you out into different groups, into the breakout rooms. And so the idea here is to designate a role for each of the group members. So there should be an examiner and a client. So the examiner will be accessing two documents on the shared folder, the bit sample test and then the script. So the examiner will have the script, exactly sort of what is the instructions to provide to the client. And the sample test is basically the different testing materials that the client needs to take a look at. So the client will also have access to that sample test to just sort of view the document as well on their end, since we're doing this on Zoom. And the client, what their role is essentially is to review each test item and complete or respond to the test as per the examiner's instructions. Okay, and so you have access to those PDF documents, and then at the end we would like the examiner and the client to basically score the bit using the scoring procedures that have been described on the bit scoring sheet PDF document. Okay, so hopefully that's clear for this task. If there's any questions, please let me know right now. But at this point, we will break out into groups. And then the second task in your small groups would be just to discuss sort of what your experience has been with the scoring procedures, how you found this tool to be either applicable or relevant in your local context, and the strengths and weaknesses of this tool and your likelihood to use the tool. We'll also engage in a general conversation after, once you have a chance to administer the bit, just to get everyone's perspective about those 4 points below. So I don't know if there's any questions. I'm not able to view the chat, but let me see if, where is this located in the handout? Sue, I don't know if everyone has the documents or.
Yeah, I sent them all before
Okay.
the second part, but I'm going to try and stick them in the chat and see if people can open them.
Oh, it says the link is expired. Whoops.
Well, that's because it was sent a week ago. So I'm just putting
Okay.
it in the chat. Let me know,
Okay.
Katie, if you can open it from the chat.
Yeah. So Sue, if you don't mind putting those documents in the chat before we break out, because I don't know if they'll be able, so at least they can access it before and then we can put the breakout.
Script bits. Let's go. I think I've put all three there.
Okay, perfect.
Right? Sample test, script, and scoring sheet.
That's right. So I see the script. Yeah, the scoring sheet's there. Sample test.
Katie, were you able to open any of them?
I'm trying. They want me to save it first. It won't just let me open it.
Okay. You just save it on the desktop.
And the last document is the script. Oh
Yeah,
yeah, you've got it. Okay,
there.
perfect. So everyone's got it all. Perfect. Okay.
I could try and quickly send a link for them too.
Yeah, it worked.
Yeah, okay. If anyone doesn't have them and needs them, just let me know.
Great.
What slide number are you on in the part 2?
Yeah, 1 second here. I'm on slide 64.
Okay, someone's just trying to catch up with the handouts.
Yeah. So I'm slide 64 of day 2's set of slides.
So we set for the breakout rooms. How long are you giving them, Anita?
Yeah, 15 minutes just to, go through just a few, it's just a few items from the bit. And then there's the script as well. So if you can take 15 minutes.
Okay, I'll open the rooms now. Is that okay?
Yeah, perfect. Thank you, Sue.
And I'll see who's.
Oops. Yes. Great. So, so welcome back, everyone. I hope you had the opportunity to review the sample test and were able to access the PDF along with the script, just to get a sense of what was the script to be used when administering the tool, and then maybe moved on with looking at how to score the items that you had in your sample test. And so just now wanting to sort of open up the floor and hear from those who've already used the bit or who are thinking to use the bit, just to have a discussion about what are your thoughts about its clinical applicability, how relevant it is in your local context, what are your thoughts about the scoring, any strengths or weaknesses, and for those who are not using the tool, maybe, would you be likely to use this tool in clinical practice, or and just having a discussion about that. So any thoughts? Feel free to unmute or indicate in the chat.
So Sarah and Emily said they've been using the bit, or at least sub-tests from it, for USN screening on their stroke unit in North Bay for the last 10 years.
Excellent. Wow. So that's great. That's excellent to hear. And what have been your experiences with using the tool? Has it been something that you felt was quite relevant? Any thoughts or any strengths or weaknesses that you discovered?
I think what we found is it's a helpful tool in it's nice to get a score that has a cutoff to kind of say whether you should do more assessment. The behavioral component, the conventional subtests we find more helpful. The behavioral ones are not something we necessarily use as much. We might use more like functional assessment once we know more about the extent of their potential neglect. One thing that's really a big barrier is the cognitive component, like understanding instructions and being able to have the attention span for it. And then also motor issues if people don't have, functional use of their dominant hand can be pretty limiting in being able to do much with it.
Right, absolutely. So, yeah. I agree. Those are very important considerations. Of course, like the conventional subtest will really assess neglect in that sort of one dimension, right, in that space. But it can give you lots of information. But you're right. There's definitely that motor component and a cognitive component for some of the items in the conventional subtests that require a bit more, that are a bit higher level, right? So this is it that maybe tap into other skills as well. Yeah, absolutely. So those are great points.
Can we just verify with the OTs at Health Sciences North, do you guys ever use the bit, and how much do you use it? You can unmute if you'd like, or just type in the chat. So in the Sault, they use the bit on inpatient rehab with stroke and with brain injury. That's Sault Ste. Marie, Ontario. And at the new outpatient neurological rehab program in Sudbury, they don't have the bit. So, and they're just opened, it'll be a year in June or July. So it might be something that they move towards. And the OTs at Health Sciences North in Sudbury do not have the bit, but they're looking into it.
Mm-hmm.
Okay.
Yeah, so that's great. Well, that's it. I think what's neat about the bit is that it, there's these transparencies or the overlays that come with the testing tools that make scoring quite efficient. So I didn't get a chance to show it, but for instance, they have like these overlays that you can kind of place onto the testing sheets. and you can then actually score the tools quite easily. And so, just, once the tool is purchased, you'll be able to make copies of the actual testing material and then use these transparencies to kind of score the assessments fairly quickly. So that's kind of the great thing with that assessment tool.
Do you know how much it costs? Do you have any idea?
It's fairly pricey. It's at least 300 and up, if I'm not mistaken, maybe even more. It is a bit of a pricey tool to purchase. Yeah, so
But it's quite expensive, so.
yeah.
Okay.
So that's sort of the I guess the downfalls of it, or the weaknesses, and so yeah. So that's pretty much what I wanted to cover about the bit. I don't know if there were any questions in regards to the tool, but hopefully 800. Oh my goodness. Okay, so much more than I had thought.
US.
Wow. Okay, thank you for sharing that information. I knew it was pricey, but I didn't realize it was that much. So yeah, it's something to really consider. I think, again, once the tool is purchased, you're able to then sort of photocopy the testing material perhaps, and then have that available to you, and perhaps the scoring sheets, but and you'll only have one copy of these transparencies. Maybe those could be copied, but it's a bit of a it's quite costly. But I think the conventional subtests do definitely lend itself to really assessing for neglect using standardized measures. And so I think that's really great. And, there's definitely, of course, benefits to a standardized assessment for this impairment. Once you have a clinical hunch or inkling that there could be a neglect, but you could decide to screen for it as well using a screening tool, which is the ones that, like the line bisection test, for example. And then, really, once you've identified the presence of a neglect through screening, then could proceed with, a more detailed assessment tool to really sort of dig and see the extent of the neglect that the client has. And it's also just another way to then, see, has the neglect evolved over time, right? So this tool will be able to capture that information as to whether the client has improved over time, and how they perform on the assessments compared to their initial assessment. So that's sort of the benefits of being able to assess for neglect with this tool. So that's pretty much it for the day 2's slides. So we'll just now move on to the next part of the lecture, which is basically our day 3 content. So I'll just share my slides here.
Lise just shared that 770 Canadian.
Oh, 770 Canadian. Okay.
So that's a little better.
Yeah, it's a little better, but again, very pricey. And so definitely need some consideration as to whether, you would want to purchase it or not. But it's been recommended in terms of best practices as the Canadian Stroke Best Practice as the tool to use for really assessing the extent of neglect in a client population, especially for those who have a mild neglect. It would be really very useful to sort of discriminate and identify those very subtle symptoms of neglect, and to really pick them up with a tool that's sensitive enough for that. So now we'll move on to looking at what can we do. So once we've identified the presence of a USN, we've assessed for it, what can we offer to the client in terms of effective treatment interventions? So this is essentially what I'd like to cover for the remaining time. So basically here are the objectives or the plan. We'll be covering just sort of the basics of neuroplasticity and principles, just reviewing that content to make sure that we're all on the same page in terms of what are important considerations that you need to think of, regardless of which intervention that you choose to use. I'm going to present to you multiple types of treatment interventions, but the underlying principles of motor neuroplasticity is really important to really adhere to maximize the improvements in this client, no matter what type of intervention you're using.
We have one late question, Anita, if you don't mind.
Yeah, go ahead.
Is the OSOT ever used? Was asked.
Yes. So the OSOT, yes, it's been used. It's a tool that I've reviewed in the past for neglect. It definitely is a tool that could be relevant, as it also assesses other visual perceptual deficits as well. However, it was unfortunately not one of the ones recommended by the best practices, and perhaps most likely because it needs more psychometric testing, but it is definitely a tool that's very useful to use to assess for visual perceptual deficits, including neglect. So hopefully that answers that. And I think it also developed in Ontario as well. So yeah, I'm sure very commonly used in the region. So in terms of the, so we'll be covering as well, so what have been the best practice guidelines and approaches for treating visual perception in USN. And then we'll finally talk at the end about sort of strategies to implement these best practices. So not just for treatment, but also for assessment, just wanting to hear from you in terms of what have been your strategies to what have you tried out in terms of treatment interventions? What has worked based on your clinical expertise, and what has been beneficial to practice? Just to share that with everyone else in terms of what's been done across the different regions in terms of assessment and treatment for both visual perception and USN. So we'll have that discussion at the end. So just to review very quickly, what is neuroplasticity? It's essentially this really incredible way that our central nervous system can essentially adapt and change in response to any cues and experiences that we have, but as well as, if in fact the central nervous system has some type of injury or disease, it's that constant ability that the brain or the central nervous system has to change and adapt itself. So this is something, this is somewhat of a mechanism that the healthy brain does have, basically to code any experiences that it has during its lifetime and how to learn new behaviors. But it's also the same mechanism that the brain has to basically relearn lost behaviors in response to any kind of rehab that's been offered to the client, in the rehab setting. There's also what we also know is as spontaneous recovery. So we know that the brain can also spontaneously just repair itself and recover in the short term from the damage that's occurred. Again, very dependent on the type of illness or disease that's happened, the extent of the damage as well. And so this is sort of the actions that happen very early on in the acute phase, where the spontaneous recovery, again, what is the mechanism for the spontaneous recovery is something still being explored and understood. But there are some ideas or some theories out there in terms of what causes the spontaneous recovery. Is essentially in the acute phase, it's more like the reduction of edema or pressure that happens in the brain structures. So, the pressure or edema that's happened as a result of the stroke, once that reduces, or once medication has been provided to the client to help revascularize the brain, so sort of, improve the circulation of blood to the brain through medications or even without medications, all that effort, including any kind of surgery that's done to sort of relieve pressure due to more bleeds in the brain, any kind of pressure that's reduced or and revascularized. That basically is what really causes, or sort of some of the mechanisms that can explain that spontaneous recovery that takes place. But any kind of spontaneous recovery that happens more in the long term, more subacute and chronic wise, is really explained by neuroplasticity. It's just our brain and its ability to rewire itself. And so what we really want to do as therapists is really promote that neuroplasticity that happens in the brain, and really recreate those new neural pathways and connections. So this is really not something very specific to stroke, but something that's equally important to any kind of area of practice in OT and PT, or any kind of rehab in that matter. So I'm just gonna go just show you a quick video on neuroplasticity that's kind of really neat, that really helps explain the concept and just really highlight the key critical points that you need to think of as a therapist when you in terms of neuroplasticity. So I'm going to play it directly from YouTube. So
not so long ago, many scientists believed that the brain did not change after childhood, that it was hardwired and fixed by the time we became adults. But recent advances in only the last decade now tell us that this is simply not true. The brain can and does change throughout our lives. It is adaptable, like plastic. Hence, neuroscientists call this neuroplasticity. How does neuroplasticity work? If you think of your brain as a dynamic, connected power grid, there are billions of pathways or roads lighting up every time you think, feel, or do something. Some of these roads are well-traveled. These are our habits, our established ways of thinking, feeling, and doing. Every time we think in a certain way, practice a particular task, or feel a specific emotion, we strengthen this road. It becomes easier for our brains to travel this pathway. Say we think about something differently, learn a new task, or choose a different emotion. We start carving out a new road. If we keep traveling that road, our brains begin to use this pathway more, and this new way of thinking, feeling, or doing becomes second nature. The old pathway gets used less and weakens. This process of rewiring your brain by forming new connections and weakening old ones is neuroplasticity in action. The good news is that we all have the ability to learn and change by rewiring our brains. If you have ever changed a bad habit or thought about something differently, you have carved a new pathway in your brain and experienced neuroplasticity firsthand. With repeated and directed attention towards your desired change, you can rewire your brain.
Okay, so I'm just gonna. All right, and let's put this down and we'll go back to the slides. So what I find fascinating about neuroplasticity is that it's something that we can definitely incorporate when we think about visual perception and USN rehab. It gives us sort of so many opportunities or so much potential to essentially look at working towards rewiring that brain and strengthening certain new pathways that may have not existed or that need to be created because those areas of the brain have been affected by the stroke. So I think it really is it's something that's really that we should use to our advantage and could really guide the type of therapeutic approaches that we use. So again, of course, as you know, plasticity happens at any age, so it happens very much internally. So of course, through neural development, through spontaneous recovery, with medication, or just the brain healing itself, reducing its edema. But it can also happen more externally, or it could be driven through rehab, our rehab offerings. And so what really is critical with, as you saw with neuroplasticity, is that repetition is very important. So lots of repetition, really ensuring that whenever we think about providing treatment interventions, that it's done very early on. And so you'll see that that's an important factor. That timing could be very important, and really wanting to maximize that period of high neuroplasticity that happens in the brain once an individual has had a stroke. So it's really looking at maximizing that timing, but then it's not to say that we can't promote neuroplasticity in the more chronic phases. So we could still continue to offer clients with USN or visual perceptual rehab, providing them with exercises to work on or anything to work on at home in terms of a home program to really promote not just the repetition, but also promote that recovery in that chronic phase. Of course, we see that age does matter. So the developing brain has a bit more plasticity than the adult brain, but it's not to say that the adult brain cannot relearn or create new pathways and strengthen those pathways as well. So it's just that it's maybe if it's a bit more facilitated in a developing brain as opposed to a brain that's fully developed as in an adult brain. In terms of pre-injury, of course, if you really need to think about what was the client's existing pre-injury skills and experiences, as of course, those pathways have already been created and can be sort of connected during therapeutic interventions. The other thing is that we'll talk about later on is that meaningfulness is very important. So you're wanting to make sure to really induce plasticity, you really want to provide clients with more meaningful activities, as that was found to improve the plasticity and that rewiring of the brain. Now, when we think of neuroplasticity, it's not really a domain specific to rehab therapists, but essentially is a team effort. So all members of the team can benefit and optimize neuroplasticity or that rewiring that takes place You know, so it could be physicians could help with medications, OTPT, SLPs, nurses, rehab assistants, even PSWs can all play an important role in terms of providing that repetition and providing them with meaningful opportunities to practice the new skills in order to really solidify those new pathways in the brain. So these are just, you know, a quick review of the different guidelines for neuroplasticity and the 10 principles that really need to be kept in mind when we think about, you know, what kind of treatment intervention do we want to design for patients with USN or visual perception. And so, you know, when designing or developing those treatment interventions specifically, and when tailoring them to the client, it's really important to think about these guidelines, these underlying principles that really will inform the kind of interventions that we're offering. So of course, what we do know is either use it or lose it. And so, you know, if we do not use a particular area of the brain or function, what ends up happening is it ends up getting lost. So as you saw in the video, those pathways weaken or become thin, and other skills can actually compete for that brain space. So through the rewiring that takes place in the brain, other skills will compete for that brain space that's not being used and might take over. So another brain function will take over that specific space. So really, if we don't use or optimize the brain area that we have in the brain areas and its functions, it could lead to loss if we don't practice. Use it and improve it. So of course, as we saw in the video, the more we use certain brain functions, that it can lead to increased or improved ability. And so we've seen that in, for example, sports. The more you practice a certain skill, you're able to improve that specific skill. Specificity. So what's really important here is, and you know, we can, of course, occupational therapists can relate to that, is that if we, you know, rather than just rote practice of a certain movement, if we really train very more occupation-based activities or use a more task-oriented approach. So if, for instance, if you want to practice toileting, really practicing, doing specific training on the toilet, really a more occupational based training or activity will really lead to improving those functions or acquiring the skills that you need to perform toileting, as opposed to doing other very rote exercises that strengthen the body but not really work on that specific skill. So that's very important. Repetition, of course, matters. So we want to really think about repetition, not just within the treatment session. So, of course, as therapists, when we think of prescribing a certain intervention for USN or visual perception, we want to make sure that we incorporate enough repetition in the activity that we're planning, but we also want to make sure that we're providing repetition even outside of therapy, right? So what kind of exercises or activities can we prescribe to the client while they're waiting in their rooms, whether in inpatient rehab and not engaged in a rehab session, but what could they do outside of therapy with their family members, with their caregivers, with the staff, in order to really promote that repetition and plasticity. Intensity matters. So we want to make sure that clients are always, you know, that we're grading the activity very carefully and that we're always providing them with the sufficient intensity and challenge that they need really to strengthen those pathways and rewire the brain. So, you know, yes, repetition is very important, but once they've acquired the skill, you know, the repetition is great, but it doesn't promote further plasticity. We really want to make sure that the brain is constantly being challenged. Again, the just right challenge, not overly challenged, but just the just right challenge to really work on specific skills and really continue and promote that rewiring of the brain and really using and occupying all spaces of the brain. In terms of timing, so we want to make sure that we provide, as I mentioned earlier, intervention as early as possible to stimulate the brain, right during, you know, as early as possible when the brain has been sort of, you know, attacked by either an illness or a disease or condition. That's the period of time that the brain tries to repair itself right away. And so we want to maximize that potential at that point, or that stimulation at those early stages. Salience matters. So what we found in the literature with the principles of neuroplasticity is that, you know, if we really think about what's meaningful to the client, what skills that they've actually acquired pre-injury, really practicing those skills and practicing activities that are meaningful to the client were found to lead to better plasticity of the brain. Of course, we've already talked about age is a definite factor among many other factors that affect plasticity, such as past medical history, diet, genetics, the exercise levels of a client past pre-injury is also important to really and can affect plasticity in the brain. Transference. So when we think about, you know, so if we're able to strengthen certain neural pathways and acquire a function, it could then relate or translate to acquisition of other similar functions or skills. So plasticity in one area or one function can actually relate or transfer to other areas of function in the brain. And then interference is very important to consider, is that sometimes what happens is plasticity in one function. So if we, when we practice a certain movement or repeat a certain movement, if we start to repeat that movement, but not in a very, not in a correct way. So if we start to acquire bad habits, like, you know, using the shoulder to compensate for the movement, what ends up happening is that that shoulder compensation ends up, that sort of neural pathway that creates that bad habit of lifting up the shoulder or compensating with the shoulder ends up getting strengthened, and that could actually interfere with good functions of the brain. So we really want to make sure that accuracy is achieved. Whenever we practice a movement, we want to provide lots of feedback, lots of correction, reinforcement, cueing during the task to make sure that the movement is being done accurately and correctly each time the repetition takes place, so that we don't have any interference happening or any bad habits sort of taking over. And then finally, the other important thing to consider with neuroplasticity and sort of these principles is that sometimes cognition could be a bit of an issue, that, you know, clients with some cognitive impairments may not understand sort of the importance of really adhering to these principles of plasticity and why repetition is important. And so, you know, having being completely aware and understanding the relevance of all of this is very important. So for a client, so cognitive status is important to have. Depression as well. Like, so if a client is not motivated, of course, that could definitely impact their recovery. And of course, pain will limit the client as well.
So there's a couple of questions, Anita.
Yeah, absolutely. So actually,
Yeah,
this is where I want to stop and take some questions and take also as well your experiences with neuroplasticity. So, is it with Steve? Like, he's wondering if we could discuss, if we could discuss post-stroke fatigue as a variable during treatment. Absolutely. So fatigue actually is, I didn't mention that as one of the criteria, or it was one of the sort of confounding factors or issues that could sort of impact plasticity. It's definitely an important factor to consider. Fatigue or level of endurance can definitely impact, just like cognition, depression, and so forth. Fatigue can be an important criteria or variable to consider that might not lend itself well to lots of repetition or that intensity that's being sort of promoted with neuroplasticity or these principles. So I think that's an important factor to consider. And so you do, you know, you again want to make sure that the client's being challenged and having that just right challenge. Repetition is important, but you do need to respect the client's level of fatigue, in terms of also promoting that recovery of the brain, right? So, and of course, as we know, post-stroke fatigue is really an important post-stroke sequelae that clients commonly have. So it really does need to be respected in terms of, not overdoing the repetition as well when it comes to neuroplasticity. So I hope, Steve, this addresses your question.
Yeah, there's another question just before we get to Katie. Krista sent me a question that you didn't get.
Okay.
She's just wondering how many of our rehab places currently have dancing or art as a way of rehabbing or encouraging neuroplasticity. She finds it's like a wishful thought.
Well, that's it, right? Like, so you're wondering about dance therapy and art? That's the question?
Well, yeah. When you're talking about,
Yeah.
reinvention
I think it was just stemming off of the fact, what did they do before? What did they love? What was meaningful? Is any of that stuff incorporated in our current idea of rehab?
Well, absolutely. So I think, salience, like as it says, matters. So I think, wanting to make sure that these activities, if it's an activity that the client engaged in pre-injury, I think, having them re-engage in those activities will, sort of bring back those motor skills. It's of course experiences that they've had that have already been strengthened, and the likelihood of rewiring those experiences are much more likely. So salience is important. And hopefully those skills can then translate to more functional skills that they would need as well, right? So I think, art therapy, dance therapy definitely has its place in terms of being able to really tap into activities that are meaningful to the client as well.
The other thing I could probably say about our region, and specifically our area in Sudbury, as a recreation therapist, that's my profession. And so there are recreation therapists working in some areas across our region. And so they definitely base their treatment on meaningful activity. And so you'll find that happening at the inpatient unit at Health Sciences North and out the new outpatient neurological rehab program. So there are some specific therapists that are looking at that as well. As we all know, the OTs look at it quite a bit as well.
Thanks, Sue. And that would be public funding at those levels?
Yeah, at
Okay.
inpatient and outpatient, that's ministry funded programs.
Thanks.
Yeah. So, and Katie, just to address your question. So Katie had a very interesting question about diet and exercise level. And so again, it kind of speaks a bit to, clients who've been a dancer or active in artwork, and, so sort of using those interests that the client has or leisure activities that they had engaged in as, activities that are salient to them, and that, they could be maybe more easily, it's functions that they had that were strengthened, or neural pathways that were strong for the client originally, pre-injury. Similarly, with clients who had a high exercise level, they may, they've already been used to sort of engaging in exercise, and so that level of repetition could be something that could easily lend itself to that type of client who's already been actively engaged and is quite active in terms of physical activity, right? So that definitely, so they've already have experience in that, and so again, engaging them in that type of repetitive movement and strengthening could be a little bit, it could be more facilitated. Now, in terms of diet, that's really interesting. So if you look at like, foods rich in omega-3s, or even vitamin D, those types of anything that promotes brain recovery. If a client has a diet rich in those types of those foods, will definitely lend itself to then improving their ability for plasticity. So any type of food that sort of promotes brain health, antioxidants as well, can definitely be useful in terms of promoting a client's plasticity in general, right? Even for healthy clients, even for health promotion for that matter. So I hope that answers your questions. But what I find fascinating about plasticity in general is that it is something that's relevant to your healthy populations. It's relevant to clients even who've had a stroke to adopt, and promote their plasticity. And it's so these principles can be used in any area of practice. But I think it also has its, it definitely has its relevance in terms of any kind of neurological condition, especially with stroke, and something to consider. So not just a question, but writing the names of people. Okay, perfect. Thank you. So hopefully that clarifies those points. So just a quick quiz, just to kind of, wrap up our ideas in terms of neuroplasticity. So these are the questions here. And if anyone could, or sorry, Sue, if you don't mind kindly launching the Zoom poll, if that's okay.
Yep, here we go.
And that you could respond to the 3 questions. I have them also as well here, and then we'll look at the responses later. So it's just sort of wrapping up the points that we covered before.
Oh, there we go. I was gonna say I have no answers yet. Does everyone see the poll?
I see it on my end.
Yeah, good. Okay. Hmm.
So there are 3 questions.
Yeah, just scroll down for all 3 questions. Twin Moon, I see you can't see the poll. I'm not sure what to do about that for you.
Hmm.
You can just answer in your head and the questions that you see on the screen.
Yes, exactly. So I have it on the screen as well, in case for those, and then just, yeah, exactly.
Are people seeing the poll? Like nobody seems to be answering.
Oh, they're all coming in.
We see it. We're just reading the questions.
Yeah, no pressure.
So again, a lot of the 3 questions are really looking at what is not a principle of neuroplasticity.
Mhm. We're at 29%, 33% answered, 37%. Another 20 seconds maybe.
Yeah, that's fine.
Okay, I think that's good. We have over 50% answered.
Perfect.
And the poll.
Thank you.
Do you
So
want me to
that's
share
it.
the results?
Yeah, sure. Thank you.
Okay.
So basically for the first question, in terms of these different statements, so essentially which is identified as not a principle of neuroplasticity. So for the first question, it's age. So, you know, many of you got that correct. It's exactly, so like the older brain learns faster than the younger brain due to past experiences. So no, in fact, what we see is a developing brain in terms of age. When we look at age, a developing brain can learn faster than a fully developed brain, because it does have a greater capacity for neuroplasticity, but not to say that you know, adult brains or a fully developed brain cannot experience neuroplasticity either, but just the rate is a bit different. Now, if we look at the next question, question number 2, which is the following is not a principle of neuroplasticity. In this case, it's repetition. So what we see here is that repetition really matters. You know, there's a bit of variability here, but it really speaks to the fact that repetition matters. So plasticity is gained with sufficient repetition, even in the presence of pain. So what we want to think about here is that so the remaining the remaining items are correct. So specificity is, I'm just going to go through them first. Specificity, so specific training leads to improved function in that specific task. So that's really what specificity is about. That if you know, you want to make sure that you are trying to use more occupation-based training, so that they would learn that, you know, that you get them to train on those specific tasks so they improve function on that task. Use it and improve it really speaks to the fact that you know, the type of whatever you offer to the client in terms of training really will dictate the type of plasticity that they will have, so that, you know, if you continue to practice a certain type of training or a certain type of movement, it will improve with that type of training as well. You'll essentially see improvements or strengthening of that neural pathways, and you will improve those you'll strengthen those neural pathways. In terms of salience, so practicing something that's meaningful or relevant leads to better neuroplasticity than something that's irrelevant. So that's true. And then finally, interferences. So plasticity of one function can interfere with another. So that's more where we talked about if you practice a bad habit and you actually strengthen that bad habit, it can actually interfere with other functions of the brain as well. So that's really where you don't want to have interference happen. You really want to make sure that you're practicing the correct movements. And then for repetition, Yes, so repetition is very important. Plasticity definitely is gained with repetition. However, we don't want to repeat so much so that, you know, the client is actually experiencing pain. That's not the goal of the therapy. So, you know, when we think of repetition, it also speaks, it kind of leads to exactly the same point about fatigue. We need to really keep in mind the client's level of fatigue, their level of pain, and we need to respect that. So it's not a question of more pain, more gain, or, you know, and continue to repeat and practice, because that pain needs to be respected. Of course, if we ignore that pain, it could lead to more inflammation and further damage. So that needs to be respected. And then finally, question number 3, if we look at the response for that. So which of the following is not an example of neuroplasticity? So learning to play soccer is, so let's just see what people had responded. Learning to play soccer is one of the best ways to improve motor function, coordination, and recovery. So when we see this option here, what we feel is that okay, soccer could be a way to improve motor function, coordination, recovery. However, if a client has never played soccer, if this is not a meaningful sport, it's not salient, it's not relevant to the client, it's not really going to be the best way in terms of promoting neuroplasticity of that client to really get them engaged in an activity that they're not really, that's not relevant to them. So it's really about, you know, making sure when we think of neuroplasticity, really understanding our clients, what their interests are, what their past leisure activities have been, and really trying to use those use those pieces of information to really guide our therapeutic approach. And so, you know, again, soccer could be relevant for someone who was a soccer player, who enjoyed playing soccer, and played soccer in the past. It would be definitely good to use that in terms of neuroplasticity, but really in that case specifically. So that's why this is selected as not an example of neuroplasticity in that case. So, any questions about that? We're good? Okay.
Can
So
you
now-
highlight, sorry, the one,
Yeah.
you want to go back?
Oh, sorry.
There was a number of people that thought after a few days following a TBI was not an example. Can you kind of explain that
Oh,
one?
yeah, I can explain that one. Yeah, the TBI
Thank you.
one.
Mhm.
Okay, so what happens is after a few days following a traumatic brain injury, a 30-year-old client spontaneously regains his short-term memory and ability to concentrate. So that can definitely happen. And that this is an example of neuroplasticity where the brain can, you know, spontaneously regain short-term memory and concentration, either, so it could happen on its own from the brain recovering and rewiring itself. So especially in the acute phases is where this could happen. And so, you know, and it could also happen just from the exposure that the client gets from their environment in the acute care setting. This is how, so that's why it's not really, this is potentially an example of neuroplasticity. So that's what that explains that one. Hopefully that's clear.
Thank you.
Thanks. So let's move on to, in terms of treatment for visual perception in USN. So these are just different approaches that you may have already been aware of or using, but you know, here's just more information about the research evidence that really backs up certain interventions, and some interventions that are maybe more considered novel or new, and have been explored in the literature, but yet does not have so much evidence of effectiveness. So I'll review those ones quickly, but I will spend more time on the ones that really have strong evidence for its effectiveness. So when we think about treatment interventions for USN and visual perception, what we really want to think about is really combining various different treatment approaches. So not only do we want to keep in the back of our mind concepts or principles of neuroplasticity and really, you know, just sort of drawing upon those principles that we just saw right now in guiding our therapeutic interventions, but we also want to think about, do we want to, you know, when do we want to use a remedial approach to therapy? When do we want to use a more adaptive approach to therapy or task-oriented approach, or maybe even co-op? We really want to be very judicious in the type of approaches that we're using. And what often happens is that we actually use a combination of approaches where we try to adapt to the environment, but also use a more remedial approach where we're trying to retrain a certain skill. So more often, so we use a remedial compensatory approach, and of course also task-oriented, where we're trying to get clients engaged in more occupation-based tasks. So another thing to think about when we think of treatment interventions for both USN and visual perception is that we also want to think about really trying to adapt or use a more compensatory approach to adapt the environment to really promote sort of success in the client's ability to scan. Right, so we want to make sure that we're really providing the optimal environment for a client to really scan as much as possible and really work on that specific skill and really strengthen that skill and that neural pathway. So what we want to do is we want to make sure that the room that we're using in treatment is adequately lit. We want to make sure that we have increased visibility of the task. So we want to make sure that we're looking at the environment and the task itself and really looking at reducing the amount of distractors or any kind of other patterns that come into play in the particular task at hand. So if we're thinking of a therapeutic task, we really want to make sure that that there's no other distractors at the beginning, and really trying to simplify the environment as much as possible so that we really focus on the task at hand and just that scanning ability without too many distractors in play. And we also want to think about what are ways that we can increase contrast. So really thinking about, if we're asking the client to scan for an object, that there's sufficient contrast between that object and the table surface. So, obviously the black and white or other colors, but really making sure that there's sufficient contrast so the client can really optimally see that object. The environment, again, making sure that the environment is as structured and organized as possible. So, and then thinking of the task being as structured as possible. So we talked about different examples. So when we use examples like the line bisection test is a quite a structured test versus the Bell's test or the star cancellation test that would be considered as a bit more unstructured and has a lot of distractors. So that's something to really think about when we're approaching visual scanning and trying to treat the clientele that we want to really think about simplifying. And the other thing is that sometimes a little trick that could be used is that, if you're working on a line bisection test or getting the client to perform the bit, you wanting to make sure that, when you place the testing material or the stimulus onto the table, that the client, could trace the edge of the table, or if say they're required to, perform a scanning task on a table, that they're just starting off the task by tracing the edge of the table with their finger, with their affected hand ideally, or their unaffected hand, but you're really getting them, or even both, getting them to trace the space that they need to scan first, just to make them aware of the parameters that they need to be scanning, right? Before they start the scanning task, so that it just brings to them the awareness of, how far they need to really sort of reach with their eyes. So that's something, another strategy that you can use. And then finally, education. So this is critical for any visual perception or USN type of treatment, is that there's a lot, and this is sort of compensation in and of itself. This is where you're trying to get the individual to be really aware as much as possible about their neglect, about their visual perceptual deficit, and use a cognitive strategy to sort of really overcome their impairment, and to really increase their search strategies. And it's essentially bringing to the awareness that the client needs to be aware that they cannot, so for a client with USN, they cannot trust their vision, right, on their affected side, because they inherently will just ignore that left space. And so just bringing that awareness to the client will help them develop what we call an intellectual override, where the client really uses their cognitive skills or their capacities to really understand that they haven't seen all that there is to their environment, that they need to continue scanning as much as possible, even if their eyes are telling them that that's all they have to see, right? So it's really like overshooting, really exaggerating their scanning beyond what they perceive visually. With someone with hemianopsia, they're a bit more aware of their impairment. So again, it's really using their cognition to really make sure that they remember to really scan their environment as much as they can to compensate for their hemianopsia and their visual field cut, because they really see half the visual field, and so that they really need to turn their head right and left to be able to see the rest of their visual field. So, and what we see is that using neuroplasticity principles, the more we repeat that visual scanning, that scanning to the affected side and scanning beyond what they see, it really sort of, that repetitive practice starts to strengthen and create new neural pathways that then leads to improvements in visual scanning. So it really reconnects or rewires the areas of the brain, their parietal lobe and their temporal lobe, as well as their occipital lobe. Those spaces in the brain that have been affected by the stroke get rewired and strengthened and improve in terms of visual scanning. So that's just general things to think about, just in terms of how we approach visual scanning. So here are just some examples that were found online in terms of therapeutic activities that could be good ideas in terms of visual perception, or activities that you might want to engage your client in, just to practice and work on very specific areas of visual perception. Now, often what we see in clients who perform the MVPT is that they have a combination of different areas that are affected in general. And so we could sort of combine and work on multiple skills at the same time. But sometimes it could be that they have very specific areas that are affected, such as visual discrimination. And so we could kind of target those areas and work on them in therapeutic activities. So these are just examples of different activities that you might want to think to use in clinical practice. Again, also thinking about what could be clients, interests and leisure activities and what's meaningful to them, and really then thinking of using those ideas to really inform your therapeutic activities. But these are just some examples that could be useful. Now, in terms of treatment approaches, we have, like I had mentioned, there's task-oriented approaches where we're really looking at really practicing the functional or occupation-based task at hand. So if a client needs to really, improve their ability to bathe themselves, both their right and left side, if they have a personal neglect, you could use a more task-oriented approach where you're essentially trying to practice the bathing activity, where you're trying to really coach them to really bathe their affected side that they're neglecting through through various different strategies, which I'll present to you later in terms of feedback. But you're using more a task-oriented approach to actually get them to practice the bathing activity in itself. And so, of course, that we know in the literature that task-oriented approaches definitely has a strong level of evidence of its effectiveness to really improve those specific skills. So if you practice the exact skill of bathing, it will then translate to an improved independence in bathing once the client goes home. In terms of remedial approaches, this is where we're going to cover more different interventions that have been studied in the literature. And so the ones that have been highlighted in bold are the ones that have some evidence of effectiveness and have been commonly used in therapy. So that's the visual scanning training, eye patching, prism therapy, and mirror therapy. I'm also going to cover virtual reality and video games and the evidence about that as well. But again, that is not as commonly used, depending on whether the equipment is available for the client or the rehab center or the clinical setting. And then we have other remedial approaches that have been documented in the literature. And so I invite you to take a look at them on Stroke Engine, where you can see a nice description about these different interventions. But I'll just, these are just a few of them, like caloric stimulation, where basically, you pour, you put cold water into the ear canal of the client to improve scanning. So cold water, in fact, will improve scanning towards the stimulated ear. So if you put the cold water towards their left ear, you will promote scanning apparently of their left hemispace, and then warm water improves scanning of the opposite field. So that's the warm water. Again, this is just very novel interventions that have been tested in the literature, but or that have been tested, and some studies have been documented in the literature, but there's not sufficient evidence to really promote its use in therapy. But these are just things that have been researched. Limb activation and rotation. So this is really activating or rotating the trunk manually or more passively or actively in order to then encourage scanning of the neglected field. Neck or hand vibration or using TENS on the affected side to really stimulate that affected side to then encourage that scanning to that affected side. The use of video feedback, so videotaping a client and then providing with that feedback at the end. Mental imagery or motor imagery. This is where you get the client to basically imagine or visualize a certain body movement and then describe that movement or describe a room based on their memory. So really getting them to sort of pay attention to the neglected side, just without actually any kind of movement, but using that imagery type of intervention. And then finally, CIMT. So CIMT, interestingly, was used to improve motor function in the upper extremity, and so it's where you constrain the use of the unaffected side. So if a client has a right CVA, you basically place a mitt on their right hand, and then basically they're left with no choice but to use their left extremity to engage in movement. So CIMT has often been used and found to be effective. But what we found in the literature is that when they were tested for visual scanning abilities, clients who use CIMT to improve motor function actually also had improvements in visual scanning ability on their affected side. So that was something that was found as an offshoot, and it was really so that, not only can CIMT help motor function, but it could help other areas of function as well. So now we're going to proceed with visual scanning training as one of the interventions that are commonly used and have strong levels of evidence for its effectiveness. So visual scanning training essentially is done in two different manners. So when we think of visual scanning, it could happen more reflexively or sort of spontaneously, but it could also happen very purposefully or voluntarily. This is where you're trying to get them to intentionally scan an area by providing them with specific cues and also getting them to practice that scanning more repetitively in a task, right? So what's critical here is in this remedial approach is really getting them involved in different scanning activities or tasks using either and really using repetition. So what's the reason why a lot of these studies have found to be very effective is that repetition as much as possible needs to be done in order for them to scan that left space. So really repeating that scanning task through a paper and pencil task, but you can even get them to scan actively scan while they're doing different functional activities as well. But that repetition of that scanning skill is really what is going to lead to improvements. The other thing is feedback. So really providing clients with sufficient feedback and cueing is very important in order for them to know whether they are scanning their field appropriately and performing well or not. So we want to really encourage them, providing them with feedback to really scan in an environment in an organized fashion. So really like from left to right and from top to bottom to really efficiently and appropriately scan the entire field, visual field. And then we also want to provide different types of cueing based on the client's needs. So it could be visual cueing. So this is where we call this anchoring. So we want to anchor their visual scanning or scan using tape or light. So we can actually place tape on the table or on the actual testing material, really to get them to really appropriately scan the field. So you, if they have a task at hand, you can just place a red tape on the table and then, cue the client to really scan until they see that red line so that they can really complete the task and really scan the full image as much as possible. You can also, for instance, if you get clients ambulating in the hallway, you could place red tape on the door sill so that, clients really need to scan their environment until they see the red tape on the door sill or on the sort of the frame of the door so that they don't bump into that door frame, right? And so that's really something that you can do to sort of compensate and really encourage that scanning of the hemispace. So that's a visual anchoring strategy. You could use lights again or tape. You could use tactile strategy, so like providing them with tactile feedback to really pay attention to the hemispace. Auditory feedback with like sounds, or even just verbal feedback as well could be provided. Another thing to consider is, providing them with that feedback or corrective feedback and positive reinforcement to know whether they are scanning the entire image or scanning the entire environment. And providing with them that feedback would be very important for them in order to correct their scanning abilities. Again, we want to think about grading the activity, making sure that they have, looking at the type of stimuli that's being provided, the speed of scanning. So initially they may take a long time to scan, but we might want to look at improving that speed of scanning, and then even getting them involved in dual tasks. So what we found in literature is that dual tasks, there were instances where clients were ambulating and scanning their environment at the same time. And so what was found is that not only did that help promote improve mobility or ambulation, but they also improved their visual scanning abilities at the same time. So really that dual task activity has been found to be very helpful and promoting neuroplasticity. And so what we see is that we want to really think about, when we think of using a remedial approach, we also want to think about, the types of scanning activities that we want to get clients engaged in. Of course, you might want to think about rote sort of tasks that require repetitive movements, but also we want to think to really bring it back to more occupation-based movements. And so using more of a task-oriented approach where we want to make sure that their scanning skills are generalizable and they transfer to more real-world tasks in the environment. So, if we want to make sure that we're getting them to scan, their bathroom so that they're able to see the shampoo bottle and grab the shampoo bottle during the bathing task, or they're scanning in order to grab the grab bar. So those are just things and ways that we want to promote scanning really in those real task or real world environments where they really need to do functional activities. So what we found in using these strategies, is that there is 1A level of evidence, so very high levels of evidence from RCTs, more than one RCT, documenting that these visual scanning training tasks have found to have improved scanning, and that clients were actually, depending on some studies, the earlier studies showed that there was minimal carryover in ADLs, but over time, what we've seen in more recent studies, this particular one that was done in 2014, that there was actually improvements in ADL function as well, not just in visual scanning, but also in ADL function, that they had improved Barthel scores on the Barthel index as well. In terms of looking at evidence for looking at what's been documented in the best practice guidelines for stroke care. So there's also supporting evidence for visual scanning training in terms of moderate quality evidence in the guidelines. So this is definitely an intervention to consider. Another sort of add-on to the visual scanning training is using the lighthouse training strategy, where here you're asking the client to imagine them being like their eyes are sweeping like a lighthouse all the way to the right and to the left to really guide the ships. And so really just bringing them to the awareness that it's important to really scan across like a lighthouse would do, and really find objects in their space. And so again, you could provide them with more cueing in addition to just using that scanning ability or scanning training strategy of the lighthouse to really reinforce. And so this is just kind of the script in terms of reminders, really turn your head like a lighthouse, find objects in the room, and just encourage that scanning strategy that could be done. Here's another strategy that was documented in the literature. This is called eye patching. So this is where you basically patch, if a client is wearing glasses, great. If not, you could get them a pair of glasses. And so it's very simple. You essentially, sort of patch or cover with tape or a particular patch, a half patch, half sort of the right half of both lenses. And so what happens is that, so if they have a right USN, a left USN, so they have a right hemisphere stroke and they have a left USN, you want to patch the right side of their lenses. the right half of their lenses. And then what ends up happening is that it's sort of like the same concept as CIMT, but it's for their eyes. So they have no choice because they can't see their right hemispace. And so they have no choice but to really scan their left hemispace. And so you might want to start off this activity with the eye patching really in a seated position where they're safe, because at this point they're not able to really see well. So, but then at some point you will actually get them to really promote that scanning of that left hemispace, you know, with that strategy. Of course, what they said was that you don't want to use the eye patching too long, because you know, they have less input from their neglected side, or well, from the right side, and so you don't want to have too long. You don't want them to have their patches on too long, but you want to have them wearing it during their waking hours and during functional activities, and then having it removed. So what's happened is that eye patching has been used for a frequency of between 1 week and 3 months in the literature. Now, unfortunately, what we find is that although there's some promising evidence for improvements, there's definitely a lot of research work that needs to be done to really solidify the evidence in this area. And unfortunately, what we saw with this is that with eye patching, it leads to improvements in visual scanning in the acute and subacute stage of stroke recovery, but unfortunately it doesn't end up translating to functional, their carryover in functional activities. I think it's when really the glasses are removed that, you know, it's really practicing the glasses, practicing the ADLs without the glasses. So unfortunately, eye patching doesn't seem to really have a strong carryover in ADLs. In terms of the recommendations for best practices, it's documented that there's conflicting evidence. So some studies promoting its use and others not supporting its use due to evidence in the literature. The next one is prism therapy. So prism therapy is essentially where a client wears a prism goggle, and they're able to basically, it really shifts their visual field towards the right. So they place the goggles on their eyes, or you could even get stickers or purchase stickers, prism stickers that you can stick onto their lenses of their glasses, and it really shifts their vision towards the right by a certain degree. So here we have 12.4 degrees. And so what ends up happening is that the client is required to wear these prism glasses while engaging in motor activities. And they are asked to basically, so what initially happens is once they wear the glasses, their vision is deviated towards the right. And because their vision is shifted, they end up, when you ask them to point towards a target, they end up missing the target, right? Because the target is in fact is not there, right? So then what happens is that through practice, so it says here in the study, after 50 trials, they realize that they need to displace their visual field towards the left in order to correct, right? So they end up sort of shifting their motor movement in order to correct what they're seeing with those goggles. And so then they actually end up touching the target. So they know that they have to actually correct their visual field and sort of displace their motor movement in order to accurately hit the target. And so in fact, what ends up happening is that once those prisms are removed, there seems to be this training after effect where they continue to displace their visual field because they're used to doing that. They don't trust their eyes anymore. And so even though their eyes are telling them that the target is right in front of them, they actually displace their visual field towards the left, and that gets to actually scan more of their left environment. So that's how prism therapy works. And of course, again, the critical thing with prism therapy is that there needs to be lots of repetition. So the more repetition, the more gains that you have with prism therapy. And so this is sort of the frequency and duration of that's been documented in the literature. Again, unfortunately, although there is promising evidence for its effectiveness, and that, you know, clients do in this case have found to have improved visual scanning and improved FIM scores when using the prism therapy, there needs to be more evidence that needs to be generated. So we need more studies looking at this and really examining it with RCTs. And then when we looked at the recommendations for best practices, there's conflicting evidence for its effectiveness. So, so again, a promising therapy that could be used, but still there needs to be still research done, but it's something to keep in mind and maybe explore as an option. So here's a short video of, just see how we are for time. So of prism therapy that I'd quickly like to show you. So I'll just escape here and we'll move.
Hi, I'm Dr. Pei Chen. At Kessler Foundation, we have developed a therapy procedure to treat spatial neglect. We call it the Kessler Foundation Prism Adaptation Treatment, or the KF-PAT. In this treatment, patients perform arm movement toward targets while wearing these prism goggles. For patients with left-sided spatial neglect, we use prism lenses thicker on the left side. They shift the entire visual field about 11 degrees to the right. During each treatment session, the patient's motor system and arm movement will adapt to the vision shifted by the prism goggles. What does it mean? Let me show you. Before prism adaptation, she can point to the pen straight from her chest. Go back. Okay, open your eyes. Now the visual field is shifted, but her motor system has not registered this shift. You can see that she does not point straight, but point to the right side of the pen and curves back at the pen. After several trials, she can point straight to the pen without correction. This means that her motor system has adapted to the visual input. Well, this is prism adaptation. All right, let's take the goggle off. Once the goggle is removed, the visual system receives the normal vision again. However, the motor system has not registered this change. Now you see she does not point straight, but point to the left side of the pen and corrects herself back at the pen. This is called after effect. This prism after effect is what we want to see in patients who neglect the left side. Before the treatment, patients do not move left. After the treatment, they do. In healthy individuals, this after effect disappears very quickly. Now you see she can point straight to the pen. Her visual and motor systems are quickly aligned. However, in patients with spatial neglect, the after effect lasts much longer and transfers to other activities. Most importantly, after a course of 10 sessions or more, symptoms of spatial neglect are reduced. I'm going to show you our therapy protocol.
So I'll just stop it right here just for the purposes of time and so that we have enough time to discuss after, but that's just to give you a snapshot of what prism adaptation therapy is like. And of course, I've kept the links there so that in case you want to go back and take a look, I definitely invite you to take a look at the remaining of the video. And so now we move on to mirror therapy. And so mirror therapy, again, is a form of motor imagery where you're essentially looking at the mirror image of you're looking at a mirror image. So you're moving your unaffected arm and you're sort of watching the reflection of your unaffected arm moving, and it sort of tricks your brain to thinking that your arm affected by the stroke is actually moving as well. But when in fact it's actually inside the mirror box and sort of occluded or covered. So it just basically gives you so it kind of tricks your brain as you're looking at that reflection, and in fact, what ends up happening is it stimulates your brain to think that you're in fact moving your affected arm in space, and when you're actually not. And so what we found is that, of course, mirror therapy has all sorts of impacts. It's found to have an important impact on improving motor function, upper extremity motor function following stroke, and promote functional recovery along with improve functional independence. But what we found in these groups of clients that had received mirror therapy is that when they were doing upper extremity exercises while watching their unaffected limb in the mirror, what ended up happening was that the group that received the mirror therapy actually had improvements in the BIT as well. So there were greater improvements on the bit as compared to those who did not receive mirror therapy. And so that's where we saw that mirror therapy can actually have benefits to other areas of function, not just motor function as well. And so in fact, what we see is that in the literature, there's strong 1A level of evidence from more than 2 RCTs, well-designed RCTs or high-quality RCTs, that document that the use of mirror therapy is beneficial for those with a subacute stroke. And there's moderate 1B level of evidence from one high-quality RCT that shows that mirror therapy can have improvements in acute clients post-stroke. And so not only do they have improvements in visual scanning, but they also carry over to improvements in motor function and ADLs in these clients who receive mirror therapy. So I've just included some of the references to that, these articles. And also there is supporting evidence that mirror therapy is in fact effective along with visual scanning training in the best practices recommendations. And so it's been recommended as one of the good therapies to use for clients with USN post-stroke. So here's an image of actually, I think, a mirror box that you will hopefully all be receiving soon. This is something that Sue had kindly shared with me. And I don't know if Ven is present here in our group to maybe speak more to that, but I think you will be hopefully receiving a mirror box and engaging in a training session with that. And so I don't know, Sue, is Ven here?
Ben's not on today, no, but I did put the date of our session in the chat, although I haven't sent out the invitation and registration yet.
Okay, perfect. So this is just to let you know. So what's very promising about this therapy is that the fact that there's quite a sufficient amount of evidence supporting its use to improve function in these clients. So something very interesting to use in therapy. So this is just a short video of just, again, here's a SIBO mirror box, but any type of mirror box, even there's some that are sort of homegrown or made, on site that could be very useful. The idea is that it's very simple. It's just simply a mirror. So I'm just gonna show you a quick video on that of what this mirror box looks like and how it's used.
Therapeutic solution that incorporates neuroplasticity-based principles, resulting in improved motor recovery and function. The SABO Mirror Box is a scientifically proven treatment tool that hides the one limb from view while providing a mirror image of the healthy limb for the client to see. During mirror therapy, clients place the affected limb inside the mirror box and the unaffected hand and forearm in front of the mirror. While looking at the image in the mirror, the client is then directed to perform movement with the unaffected hand in front of the mirror while simultaneously attempting to copy the movement with the hidden affected hand. Through visual feedback, mirror box therapy programs the brain to perceive the affected limb as the healthy one as the client observes the healthy limb and its mirror image while performing specific exercises. When looking into the mirror, the client observes the reflection of the unaffected limb as the affected limb, creating the illusion that both limbs are working normally. Research shows that hand function can improve following a neurological injury when mirror therapy is performed for 30 to 60 minutes per day, 5 to 7 days per week. Therefore, successful outcomes may be achieved if the mirror therapy exercises are routinely performed at home by the client. Our compact, foldable, one-handed, affordable mirror box makes home therapy easy, as it only takes seconds to set up and fold flat for each.
So we'll just stop there and get back to the slides. So just again, any type of mirror box would be sufficient, but the idea is that there seems to be strong evidence really supporting its use, and it really relates well to neuroplasticity and really strengthening those neural pathways by sort of tricking the brain that both sides, both their upper extremities are working, and really then promotes that visual scanning to the left field. And Finally, we have virtual reality and video game-based training for clients with visual, perceptual, and USN deficits. And so what we know from, again, this is really something that's up and coming. There's a lot of supporting evidence, but we do need to understand a bit more about the nature of the activities and the repetitions and the protocols to really be able to more accurately prescribe it to clients. But what we do see is that, what's really unique about virtual reality and video game-based training is that, most of the exercises or the environments, the virtual environments could be adapted. The stimuli could be adapted. The level of difficulty could be adapted. So that's what's really neat about these games, is that things could easily be tailored to the client's needs. Using different parameters, that clients often get that real-time visual feedback and reinforcement. So it could be something that's used as an adjunct on top of rehab therapy, but also something that could be used outside of the therapy time. Again, with supervision, making sure that the client is safe is very important, but it really gives a client more awareness, and it helps facilitate learning with feedback about their performance using these various, especially like, software like Connect, where the client, gets immediate feedback as to how they perform the activity. Gentronics is also another company that provides these type of video gaming training and provides clients with that feedback as well. Interactive tasks. So clients are engaged in different types of interactive tasks, and I think this more immersive, interactive nature of training really provides clients with a therapeutic activity that could enhance their motivation, their adherence, their engagement, without really realizing that they're doing multiple repetitions, and their adherence to the task as well, and then their engagement in rehab activities. But what's really important is that you definitely need to have somebody trained next to them to really observe the client as they're performing activities. So you want to make sure that they're not repetitively performing things in a way that's actually detrimental in terms of like acquiring bad habits or acquiring bad movements. You want to make sure that the client is able to perform those repetitive movements correctly, and that they receive the appropriate feedback to correct their movements as well. So that's really important when it comes to virtual reality or gaming, is that there's correct feedback and that the client is being corrected whenever they're adopting bad movements. And then the other thing is that what's really great about virtual reality is that a lot, depending on the environment, the virtual environment or the scene, is that there could be real world transfer of these skills, so that skills that are gained or strategies that are gained in these environments could be transferable to everyday activities, navigating through crowded spaces, for instance. So again, lots of promising research that's being done in this area, and supporting evidence that supports the use of virtual reality and video gaming. There's evidence, it's been also supported in the best practice guidelines, but again, more research is needed. And also we need to really think about the ecological validity of these tools or these interventions. So, we want to make sure that the virtual scenarios that are being created are really representative of real life scenarios, and so that that the skills that are gained from these activities are easily transferable to real life. And so that's where the research is going towards. So here's just an example of that. And so I'll just go back to.
This is a demonstration of what a participant sees while performing the Virtual Reality Lateralized Attention Test, or VRLAT. The VRLAT is a sensitive and easily administered assessment tool for the detection of hemispatial neglect, a very common deficit in people who have suffered a stroke. Neglect results from damage to the parts of the brain that control the ability to pay attention to objects and events on the opposite side of space, and may be highly disabling. The participant's task is to navigate down a winding path using a joystick, while naming all of the colored trees and statues along the way. A number of visual and auditory distractors are present, increasing the sensitivity of the task. Participants' ability to name objects on the left of the path are tallied. Scores are compared to established normative data from a large sample of stroke patients and healthy participants. The neglect syndrome is associated with decreased safety, increased risk of falling, increased caregiver burden, and poorer rehabilitation outcomes. Although there are a number of assessment instruments used to detect neglect, most suffer from lack of sensitivity.
Sorry, just stop that.
In addition,
So that's just to give you a quick visual as to what the, a virtual reality. I apologize for the graphics because I think as I increase the size of my screen, it sort of blurs it out, but which doesn't help for a client with a visual impairment. But anyway, but just to give you an idea of the fact that you could use different types of virtual reality games or training to really help the client to scan the environment in a way that's safe. They could be seated at a chair. So if they don't have that motor function to be able to sort of ambulate and walk and scan at the same time, they can easily be seated at a chair and perform the scanning task and really see how quickly they can pick up objects or scan and visualize objects in their environment and really react accordingly. And so, although again, it's with a joystick, but these are just ways that you can engage clients in virtual reality, not always in a standing position, but also seated as well. So you can adapt the task in the virtual reality game or training based on the client's level of function. So just a final thoughts in terms of like important considerations to think about when implementing best practices for visual perception in USN treatment is that we want to think about, we always want to think back. So when we think back to all, sort of what we've seen so far in terms of different types of interventions, we really want to look at, what's the research evidence that's been documented in terms of supporting and testing the effectiveness of that particular treatment strategy. We also want to understand and what helps us decide whether we want to use that treatment intervention, not just, whether, okay, great, the research evidence supports it, but, what's that treatment protocol like? Is it clear? Is it actually feasible in clinical practice? Do we agree with it? How easy is it to use? We want to think about client appropriateness, like in terms of functional or physical requirements. Is this feasible in clinical practice? What are the cognitive requirements? We talked also about, endurance. Is this going to work out with our clients and whether it's relevant as well? Do clinicians actually believe that clients can improve in terms of outcomes? And so what, do they feel like, in spite of the research and the treatment protocol that's there in place, do they expect the positive outcomes that have been demonstrated in that evidence, and do they actually believe in it, is very important. So the clinician's perspective is highly important in terms of whether they would decide to offer to a client or not. Do they have the required time and space to offer these treatments? The cost of where to buy the equipment, again, training to be able to offer these different treatment interventions. And so, that's an important consideration to think of. And so, do they feel like they have the sufficient skills and knowledge in the area to really offer the treatment intervention as per the protocol and yield those benefits? And then finally, motivation to change practices as well. And then, of course, the organizational culture is very critical. So an organization or, managers, colleagues that support practice change and that support best practices is very influential in terms of, helping us decide whether we would lean towards any of these treatment interventions that are supported by the literature. So I'm going to pause here to really get some feedback in terms of what are your thoughts about what we saw so far? What are your thoughts about the different interventions that were presented today? Have you used any? What have been your experiences? So feel free to share in the chat or or just unmute and share out loud. Oh.
I'll just start while people are typing in the chat for the virtual reality type things. Are they all, do they all cost money or is there any free things out there?
I am not
No?
aware of any. Yeah, yeah, I'm wondering if any of you have come across anything free, but I haven't come across any of the software that's been provided free that could be used. So again, that maybe I'm wondering if that would be interesting to know whether some of the ones that could be done at a computer screen, maybe those could be because the others may require more equipment to the VR equipment in terms of the headset and the equipment to really record information.
Yeah, I
So
know here in Sudbury they use video games, so they have a little bit of a video game system, and they can do, Wii bowling, or there's a
Yeah.
variety of things that they utilize. I'm sure people have
Yeah.
heard of, but you have to purchase the machine and the game, and then that's kind of a one-time cost.
Right. So those are just equipments that are a little bit more easily available and accessible in the community, and maybe even accessible for the client in their home. Maybe
Mhm.
they have a grandchild or a niece or nephew or someone in the family who has a gaming console that could possibly lend them, but again, it would definitely need to be something prescribed very carefully, then in a way that they can perform it in a safe manner and be supervised. But yeah,
Yeah.
it could be a possibility. So I see Rosalind, she was mentioning that not virtual reality, but for scanning and visual perception, we use the free website I Can Learn. Oh, great. Okay, that's interesting. Thanks for sharing that, Rosalind. Any other resources that you've come across, or any thoughts about any of the treatment interventions that we saw today that you felt would be useful, or that you might think to consider using?
The outpatient neuro rehab program also uses the I Can Learn, so I think a few people have heard of it.
Oh, great. Any other thoughts about any other resources that you came across?
I don't know if anyone has any questions about the eye patching and prisms, and if you need some professional advice for that in terms of ophthalmology or something like that. I'm not sure how much we use here in Sudbury, but I'm be interested to hear what people are doing in terms of those treatments.
Has anyone explored any of this and had any successes or any sort of lessons learned? Or any visual scanning strategies that you found to be very effective? The visual training strategies, rather?
The outpatient neuro program in Sudbury said they have a visual attention app for the iPad. But
Okay.
you can only use the free version at this time.
Okay, interesting.
So visual attention app for the iPad.
Okay. Sorry, Krista, I don't know if you wanted to say something, or you had muted at one point.
Oh, I really don't have any experience. Like, I'm in primary care, as I said before, but
Okay.
I love the lighthouse. That totally made sense to me, like the one that you shared.
Yes.
That's easy to easy concept, and really that generation. Well, everybody knows what a lighthouse does, but yeah, thanks.
It's kind of that's the concept of the fact that like they understand the importance of that scanning and really not missing anything, and so it really speaks to the client, and then just yeah, and then they just incorporate that. So thank you.
Rosalind's
and
asking if it was the Tactus one for the visual attention app, and it is.
Okay.
Tactus.
And just and the lighthouse strategy, if you just you can Google it and you'll see it's a specific. It's been tested actually and documented in the literature. So it's a specific strategy that a bunch of researchers came up with and was found to be very effective. And so they kind of I included the sort of the description of the script of what you need to say, and it was found to be useful. But okay, so I'll move forward. So there's a quiz at the end, but I'm not going to go through it because with the purpose of time. But I've basically, I would invite you to take a look at this on your own, and you'll see the responses. I will send you another set of handouts that really have the responses to each of these questions or each of these statements, but it's really just applying whatever we saw today, but even just in general, in terms of like what could be, so if we tried to place, for example, a client has a food tray placed on his right side, that would be more using an adaptive approach to therapy. So different therapeutic approaches that we could use with a client. So a client wears his glasses with right half eye patches and performs a bathing task while seated on a bench. So in this case, yeah, it's more using a remedial approach, using eye patching, and it's task oriented because we're having the client do a more functional occupation-based task. And then finally here, client practices his right and left arm swing while walking in front of a long mirror, usually using visual feedback from the mirror and a more task-oriented approach of therapy. And again, remedial because they're sort of practicing it repetitively. So these are just examples of different types of treatment approaches, interventions, strategies that are all listed here, and that you can kind of take a look, and so you'll have all these responses for you at the end. So that was that for, and that's pretty much it. So this is just a little image that I found, which was interesting online, but it was of a dog who had, unfortunately, the presence of a neglect. So I'm not sure what the diagnosis was for this guy, but unfortunately had the presence of a neglect, and so ate really half of the food on his plate, which is very unusual for a dog to do, right? And so they would rarely, of course they would use their sense of smell maybe, but here like really leaving half of their food on the plate. So just wanted to just leave that with you at the end. So I thank you all very much for your engagement. I really enjoyed these 3 sessions, and I hope it was informative. I hope you had a chance to get your hands dirty and enjoy and sort of learn about the different assessments and treatments. And I encourage you to confidently try something out new with your clients with USN and visual perception. So I hopefully this inspired you, and I see some other thoughts about different resources. So thanks so much for sharing them as well, and I hopefully all of you walked away with something new. So that's
Thanks so much, Anita. That's was a really great 3-part course. I've put the evaluation survey link in the chat a few times. If you could just click on it, it's very short, helps us in moving forward with new education and improving education in the future. And I will send the summary to Anita when I've summarized all the evaluations. We'll also send out a certificate of participation next week to everybody that participated in this course. And I just want to say again, it was really relevant, this course, really helpful. Some people knew some of this stuff already. It's a good reminder, but we've all learned something new. And I think it's going to be really helpful in moving forward in our perception work here in the Northeast. So Anita, I really appreciate you doing this for us, and thank you very much.
Absolutely. Thank you very much again, Sue, for the invitation, and I wish you all a wonderful day. Thank you.